Hello and welcome to this video on making sense of laboratory results. I'm Professor Anthony Cummins and this is from the Department of Family Medicine at RCSI Perdana. I'm very grateful to student BMJ for use of this article. Okay, when you're explaining laboratory results to patients, what's the bottom line? I think it's very clear from the outset that it should be pointed out to patients that many minor test abnormalities in otherwise well people have no clinical relevance. By definition, 5% of healthy people, that's 1 in 40, will have test results that actually fall outside the 95% healthy population reference range. So they're either below it or above it, but it's not necessarily clinically relevant at all. We should also consider the possibilities of false positives and false negatives, and be aware that the predictive value of tests, either as a negative predictive value or positive predictive value, will vary according to disease prevalence. Regardless of the result, and particularly if the result is negative, if your clinical suspicion of an underlying condition is high, then this person will probably require to be referred further to clarify. One of the problems of speculative screening tests in otherwise well people as part of so-called executive checks, etc. They have little value, but they do result in harm through over-investigation, over-diagnosis, and unnecessary treatment. Please, after this video, have a look at the section on overdiagnosis on Moodle. Now, patient satisfaction with their healthcare delivery may be better if they have a better understanding of why tests are performed and what the results mean. And increasingly now, through online portals, people have access to their results and may discuss these with each other, with family, friends, colleagues, or via the internet. However, the legal responsibility for explaining test results lies with the clinician who has ordered the tests. And when giving the results and interpreting the results to patients, please take into account their literacy, and in particular their health literacy, and also their numeracy level. Tests are performed for a variety of reasons. The more commonest reasons would be, first of all, to make a diagnosis, to either confirm or exclude a diagnosis. Where there is a high clinical suspicion, for example, if somebody has thirst and increasingly passing lots of urine, you may suspect type 2 diabetes, in which case the fasting blood sugar or a measurement of glycated hemoglobin would be useful. Tests may also be done for monitoring. Having made a diagnosis and treated the patient, you may then want to monitor their ongoing progress. For example, using a PSA, or prostate-specific antigen, in monitoring prostate cancer, or using EGFR in monitoring patients' chronic kidney disease. Tests can also be done to risk stratify and therefore give some idea of prognosis. So, for example, levels of cholesterol or LDL, HDL cholesterol in patients with underlying heart disease or type 2 diabetes to quantify their cardiovascular risk. Screening also is a useful way of employing tests to try and pick up disease earlier, with the hope of improving long-term outcome. Screening is not universally a good thing, however, and some screening tests and some screening procedures are associated with probably equal harm as benefit, in some cases more harm than benefit. So, for example, in men with a localized non-aggressive prostate cancer, the benefits of screening with PSA and others is limited. Similarly, for mammography and breast cancer screening, Now, just be clear that this is not the same as doing these investigations in a woman who has found a lump in her breast. This is not screening, this is a diagnostic test. But there are some screening tests that are beneficial, like fecal occult blood test for colorectal cancer screening and neonatal screening for inborn errors in metabolism. What about the patient who gets a blood test done and finds that their level is lower than normal or higher than normal? So let's say the example here, my sodium level is slightly low at 131 millimoles per litre. Is there something wrong with me, doc? The problem is that 1 in 40 people are somewhere outside the reference range of 95%. So 2.5% either side of this Gaussian distribution. But that doesn't mean that it's clinically relevant or that you are abnormal, even if you are statistically outside that reference range. Reference ranges also were usually done on white, middle-aged populations, and they take no account of the elderly or ethnicity, and therefore in a particular patient may not be that relevant. It's important, therefore, when doing tests for the first time to explain to patients that these reference ranges have their limits. Also, there's a potential problem when doing multiple tests, and nowadays doctors will order a so-called battery of tests, quite a large number of tests, and as the number of tests increases, then the possibility that an otherwise healthy person falls outside the reference range may jump from 5% when a single test is done to up to almost 70% when 20 tests or more are performed. So getting back to the sodium level, 95% of people have their sodium level somewhere between 133 and 146 millimoles per litre, but 1 in 40, that's 5%, will have a reading just below this or just above it. But it's unlikely to be significant if they are otherwise well. This shows you the distribution. Here's the Gaussian distribution. So 2.5% of people are about around here and 2.5% here. And in this here, you see the overlap between healthy people, true normal, true negative results, and people with disease with true positive results. And there's a proportion in here where there's huge overlap. Some of these may have a negative test result, but may actually have the disease. This is known as a false negative. So, if there's any doubt, if there's clinical suspicion that this person may have the disease, and in some countries, celiac disease, as an example, is quite prevalent. For example, in my country, Ireland, it's 1 in every 200 patients will have celiac disease. So, because of such a prevalence, if patients have symptoms that could be due to celiac disease, it's generally worth getting these tests done. In countries where it is much less prevalent, such as Malaysia, this would have much less worth and value. So if you have clinical suspicion, even though the test comes back negative, then you would probably refer to gastroenterology for further investigation. You can see here the differences. For example, looking at a test called fecal elastase, which is sometimes used to assess exocrine pancreatic function, has a reported sensitivity and specificity of 75% and 95% respectively. But in a hospital patient group, in which the prevalence of chronic pancreatitis was 8.5%, a positive fecal elastase test had a predictive value of exocrine pancreatic insufficiency of 58%. In primary care, however, the prevalence of exocrine pancreatic insufficiency is much, much lower, and if the test is applied to that population with a disease prevalence of 0.1%, the positive predictive value goes from 58% right down to 1.2%. So it's all to do with the prevalence. Here's one where patients had serial cholesterol levels. said my cholesterol level was 5.7 millimoles per litre. I improved my diet, but now it's gone up to 6.1 millimoles. Why, Doc? There's huge variability within these continuous variable results, such as cholesterol, blood pressure, and so forth. So there may be already some pre-analytical variability, for example, at the time of sampling, fasting, hydration status, exercise level, delay in sample centrifugation, delay in transport to the laboratory, etc. There may be analytical variability, which arises from random error in measurement in the lab. There may be biological variability, a random fluctuation around the homeostatic set point. So if a test is affected by cyclical rhythms, diurnal variation, such as gonadotrophin, sex hormone levels in women, testosterone in men, this may be quite significant. And even other tests may fluctuate a lot. For example, it's reckoned there's about a 6% variation for total cholesterol and 5% for creatinine. So these levels will vary from day to day, even in the same person. And so this small change, relatively small change, is well within the 6% variation that's allowed for cholesterol levels. But a doctor would have to know this to be able to reassure that patient that there's no significant difference, that there's no need to make any changes in statin dosage, for example, because of this variation from 5.7 to 6.1. So if you look at a result of 6.1, the true level, the true result is somewhere between 5.4 and 6.8. And so for a level of 5.7, it would go between 5 and 6.4. Therefore, there's overlap between these two ranges. And the differences between the two results of 5.7 and 6.1 may simply reflect the expected 6% variability. And another case where somebody has a cholesterol level that they think is high and wonder why they're not being offered treatment. So testing can be used as risk stratification and deciding about treatment. So for example, in patients who have no prior coronary artery disease, but have a coronary risk predictor which suggests that they have a 10% risk over 10 years, then you may want to treat them even if the cholesterol isn't particularly high. Serum cholesterol on its own is a relatively poor predictor of overall vascular event risk. However, combined with others, and this is how these cardiovascular risk charts are developed, combined with age, gender, comorbidities, family history. For example, QRIS2 is quoted here, but there are several of them. It may then contribute to a more robust measure of absolute risk over a period of time, conventionally 10 years. So two patients may have identical cholesterol levels, but different cardiovascular risk. And one may be offered cardiovascular therapy such as statins, even though the level of cholesterol is no greater, and the other may not. And instead of talking about risks and profiles and percentages and so forth, it's probably better to use this. It was developed initially for children with acute otitis media by Dr. Chris Cates in North London. It's now widely used. It can also be used for patients who are illiterate or unable to understand the message given by the printed text. So you can explain what the risks are in real terms in the case of 100 smiley and non-smiley hearts, the faces for them. So with the use of the risk chart, you can calculate that even though your cholesterol level has increased, your risk of a heart disease event such as a heart attack or unstable angina or death over the next 10 years is low, because you're otherwise healthy, you do not smoke, you have normal blood pressure, you have no family history of premature coronary artery disease. Therefore, because your overall risk is very low, the benefits from taking a cholesterol lowering tablet such as a statin at this stage in your life is also likely to be low, and you have to balance that against the likely side effects from statins such as muscle aching, myopathy, and possibly myoglobinuria. In reviewing this section here, please also check the section on screening in the first of the evidence-based medicine Moodle presentations. It's quite important, and it refers also to the concept of overdiagnosis. Screening tests are for people who have no symptoms, and then subsequent tests used to confirm the disease, so neonatal screening, for example, fetal occult blood, and so on. And the underlying premise is that early detection is good when you are symptom-free, because it allows us to pick up the disease at an earlier, more treatable phase, and therefore improves long-term outcome. So although some tests for a cancer diagnosis are used as monitoring tests in people with the disease, as predictive tests, as screening tests, they're of limited value in otherwise healthy people. They lack the sensitivity, so therefore, and specificity, therefore they will miss some cancers, and they will give false positive results in other situations. And the lack of specificity means that those patients who are deemed to have an abnormal result may then go on to have further inappropriate investigation and possibly unnecessary treatments. However, in those who have a diagnosis or symptoms of the disease, then tests such as tumor markers are more useful. Similarly, for PSA in prostate cancer, as a screening test, not very reliable. As a monitoring test, of more benefit. And the issue with when patients are asymptomatic, you can't make asymptomatic patients feel any better. By definition, they have no symptoms. You can't make that, you can't improve that with any drug or any procedure. But if a man has a prostate-specific antigen test that's deemed to be abnormal for his age band, then he may go on to have further diagnostic testing. Now, the difficulty here is that if he's one of those men who turns out to have a non-aggressive cancer or no cancer, then the further diagnostic tests themselves can be quite harmful. So, prostatic biopsy is not without risk. It renders men impotent, it renders them incontinent. Treating a low-grade, non-aggressive cancer with radiotherapy can give rise to harmful effects on the bowel, which also gives rise to fecal incontinence. So if a patient asks to get some cancer blood test done as part of a general health check, if the patient has no other features that have raised any concern about cancer, you should explain that cancer blood tests are not useful here as a screening test at picking up a cancer. They give a lot of readings that are either false positives or false negatives, and they're mainly useful for following up or monitoring or keeping a check on those with an established cancer. So in conclusion, it's important to explain test results, but put them in the context of the patient's overall condition. A better understanding of test results, of why they are done, and so on, may improve patient satisfaction with their care. Thank you.